A very good afternoon, everyone. It is with great honor and pleasure I welcome you all to this 20th Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. The Eco Clinic is a dynamic platform for case-based clinical discussions and dissemination of knowledge and bringing all experts together across the country for managing tuberculosis among children. On behalf of the National Institute of Tuberculosis and Respiratory Diseases, I extend a very warm welcome to our esteemed Deputy Director General TB Central TB Division, Dr. Shobhini Rajan and her team. I also extend a heartfelt welcome to the directors, representatives from NIRT, NTI, state TB officers, directors of STDCs, esteemed faculty from medical colleges, district TB officers, medical officers, and pediatric TB specialists, and all healthcare professionals participating in today's session. Now, please let me introduce the faculty from NIT RD. I'm Dr. Dhulika Dhingra, Specialist Pediatrics at NIT RD, and I will be moderating today's session. And with me is Dr. Sangeeta Sharma, Chief in charge of the National Center of Excellence for Pediatric TB and also former Director of NIT RD. To my extreme right is Dr. Alok Yadav, CMO, NFSG and Pediatrician at NIT RD. To formally start this session, I would now request Dr. Sangeeta Sharma ma'am to please address the gathering and also welcome our DDG ma'am, Dr. Shobhini Rajan. Over to you, ma'am.
Thanks, Dr. Dhulika. So we are gathered again. This time there was a date change because of our pedicon. Sorry about that, but nevertheless, that gives us that we are not so many who have logged in. Probably the reason being the long weekend. But whatever it is, it's a very interesting case, and I'm sure whoever has logged in will thoroughly enjoy the discussion because the presenting team is none other than MAMC, New Delhi. So it's my privilege to welcome our new DDG TB ma'am, Dr. Shobhini Rajan. She has been associated with the NACO for a very long time. I think I know her for last almost 25 to 30 years in NACO. And her wisdom of the HIV control in our country will be carried forward for our TB elimination program. So, without wasting words and my time, I'll now request our DDG, Dr. Shobhini, to say a few words. Is Dr. Shobhini joined?
Okay.
Okay, just ask her.
In the meantime, I would request the audience to please attempt the pre-test, the link for which has been shared in the chat box.
DDG ma'am will be joining soon, as she had conveyed to me. So now I'll request Dr. Dhulika to carry the proceedings further, and then we'll take a very short break when our DDG TB ma'am she joins in. So over to you, Dr. Dhulika.
Thank you, ma'am. So without any further delay, start today's session. Presenting team, as ma'am has already mentioned, is Department of Pediatrics, Maulana Azad Medical College, and the team is led by Dr. Anurag Agarwal, Professor, Department of Pediatrics, Maulana Azad Medical College, and associated Lok Nayak Hospital. The case presenter is Dr. Shireen Rana. She's a senior resident in Department of Pediatrics. The case expert is Dr. Anurag Agarwal, and the national expert for today's session is Dr. Sangeeta Sharma. Over to you, Shireen. You can now share your screen and you start your presentation.
Am I audible, ma'am?
Yes, Shireen, you're audible. You can now share your screen as well.
Okay, ma'am. Ma'am, is the screen visible? Hello.
Not yet.
Shirin, it is not yet visible, Shirin.
Sir, once.
Give it a moment. Now it is visible. I think now we can make it full screen now
Sir, it is already full screen.
from your end. No, no, now it is
Yes,
full
sir.
screen. Okay, so there's a slight delay in transmission. So,
Okay.
good afternoon, respected chairpersons and participants. Dr. Shirin will be presenting a very interesting case, and see, it is a department of pediatrics. So, uh, when we get a patient, it is we have a pattern of signs and symptoms, and we try and follow up and reach to a diagnosis. So here you will be finding that how the case how the case went down the line, and what problems we faced, and the amount of treatment we gave initially, and what the diagnosis turned out to be in the end. Yes, we took a lot of expert consultations from multiple super specialities to try and reach to a diagnosis. And Dr. Shirin will be going through that rapidly. And I request Dr. Shirin, you can please start now.
Okay.
Or
Good
are we still
afternoon,
going with
everyone.
just a moment, are we still going through with the pre-test questionnaire, Dr. Dhulika? Or should we start?
You can start, sir. Let's start. When ma'am will join. Acha, ma'am has joined. Okay, just give us 2 minutes.
So we have our DDG TB ma'am who is joined in, Dr. Shobani. I request Dr. Shobani Rajan to please give her opening remarks.
Thank you, Dr. Sangeeta, and apologies. I received a call at dot 2, so I could not join on time. A very good afternoon to everyone. I believe we have state TB officers, STDC directors, nodal officers from the nodal and district drug-resistant TB centers, our medical college faculties, WHO consultants, and many other, of course, the experts at NITRD, who are, in addition to one more meeting that I had attended for adults, difficult to treat adults, you also are doing this emphasis on pediatric TB and doing this national difficult to treat TB clinic. I really would like to congratulate everybody on dais and who are there on the NITRD group. So, as you are aware, pediatric TB poses unique challenges, specifically in the diagnosis due to non-specific clinical presentation, difficulty in obtaining microbiological confirmation, and a frequent reliance on clinical and radiological judgment. So, these are further compounded in case of drug-resistant TB, extrapulmonary TB, and TB in young children and adolescents. So, it does require specialized expertise, which I know that the group that has joined us today has in good measure. And we need to really interpret what we see and take each decision very carefully when we are dealing with pediatric TB. So we have given out guidelines for management of drug-resistant TB, and in certain complex pediatric cases, even the nodal DRTB center level does not feel fully confident in managing these cases, which requires discussion and consultation with state level and national level experts. So I congratulate uh, everybody who's part of this system, where we have established this state level difficult to treat TB clinics in 32 states and union territories, and where we have geared up to provide expert support for pediatric cases. So with this little bit of background, which I know is more like taking the preaching to the already wise people, I'd like to request you to go ahead with the session. And this National Pediatric Difficult to Treat TB Clinic will continue to play a crucial role, not only in cross learning, but also in strengthening clinical decision making, and most importantly, improving the outcomes for children with TB and drug resistant TB. And over time, we expect that it will build sustained capacity across the health system. So, thank you. Please go ahead with the session.
Thank you, Dr. Shobani, for your inaugural words. We are in our second year, which is nearing completion, and this session is held usually every third Tuesday, 2 to 3 p.m. And we have various institutes from all over India who participate and they present their difficult cases, and it's a good learning experience for all of us. So now, Dr. Dhulika, please carry forward the proceedings.
Thank you, ma'am. So we'll now continue with our case discussion. Dr. Shireen, you may now proceed with the discussion. You can make the slide, make it into a slideshow because.
Yeah, make it full screen, please.
Dr. Shireen, you can share this slide with us, your presentation. We'll upload it from our side.
Shirin, are you there? Is there a problem? Hello, Shirin?
Dr. Shireen has joined.
Yes, ma'am, I'm starting with the PPT. Am I audible, ma'am?
Yes, yes.
Yes.
Good afternoon, everyone. I'll be presenting today a case of pyrexia of unknown origin with multiple organ infarcts. I'm Dr. Shirin Rana, senior resident in the Department of Pediatrics, MAMC and LNH, and our case expert is Dr. Anurag Agarwal, professor in the Department of Pediatrics, MAMC and Loknaik Hospital. So we'll be discussing in this presentation under 4 parts: the history and examination, the course and differential diagnosis, the review of literature, and the final diagnosis and current status of the child. So we had an 8-year-old female. She was a resident of Uttar Pradesh. She studied in class 3 and the informant was the father and he was reliable. The patient presented to us with a complaint of fever since 20 days, pain abdomen since 15 days, and she had an accidental glass shard injury to the sole of left foot 5 days before presentation to LNH. She was apparently well 20 days before presentation to our hospital when she developed fever, which was 102 to 103 degree Fahrenheit. She was having daily fever spikes since the past 20 days, and the fever relieved temporarily with oral medication only to reappear. There were no chills or rigors. There was no diurnal variation in the fever or any evening rise of temperature. There was no associated rash. To begin with, the fever spikes were 102 to 103, and over the course of 20 days, they spiked up to 104 degree Fahrenheit. She also had pain abdomen, which developed on the day 5 of illness. The pain abdomen was insidious in onset, intermittent, and mild in nature initially, which progressed to moderate to severe in intensity, and it occasionally disturbed the child's sleep. The child described the pain as being sharp, pricking type of pain. It involved the entire abdomen. It was not associated with any food intake. There was no radiation of the pain. There were no aggravating or relieving factors. There was no history of odd bowel habits. However, it was associated with loss of appetite. There was no vomiting, loose stools, or abdominal distension, no yellowish discoloration of skins or eyes. no burning micturition or increased frequency of micturition. There was no bleeding from any side, no headache, neck pain, increased irritability, abnormal body movements. There was no history of any cough, coryza, ear discharge, and there was no history of back with the shit. With the above mentioned comments, the child was admitted in the hospital when patients were sent. We did not have had any records of the patient when she came to us. There was only a CBC of the patient in which the platelet count was 61,000, and there were no other records available. The child continued to experience continuous fever spikes throughout the hospital stay. The pain in abdomen worsened so much that the child would not allow the mother to touch her abdomen. The CCT was planned by the private hospital. Incidentally, during that hospital stay in the private hospital, she also suffered an accidental glass shard injury to the left from a broken arm.
Kiran, we have lost you. Your net seems to be poor.
Shall we upload the slides from our end, sir?
I think that would be better.
think that-
So if you have a set which she sent you,
The one that I sent her.
no, I think she's back. This is Shirin's set, no?
No, this is our set. I've asked her to share the last PPT, the last one that she made changes.
It's my request to all the presenters who are going to be presenting in the future. Please, I sincerely request you with folded hands that the presentation should be in our hands at least 3 days prior. And initial draft 1 week prior, because the list is already prepared. Although this Mansi team came at the last minute because I had a date change. So they are being excused for this, but for others who have logged in now, you are finding it like everybody wants a free flow of knowledge, rather than these interruptions. So with this background, I would request you once again, to please cooperate with Dr. Dhulika. She is doing her level best to coordinate this pediatric TB eco session. A lot of hard work goes behind the scenes. So, as the list is already there, we need to be already uh, in the know-how that this is our final set and share with Dr. Dhulika, because we have some changes as per the NTEP, so that we are ready at least 2 to 3 days prior. So I think she's back again, Dr.
Shirin,
Sheen.
are you there?
Yes, sir, I'm there.
Actually, what happened? Your net disconnected.
Actually, there was an electricity issue in the hostel. I've connected to a different network, so it won't be an issue now.
Okay,
Chalo,
okay, never mind. Yeah, chalo.
Yeah, please continue.
Yes, ma'am. Ma'am, I've shared the slides with you as well, Dhulika ma'am.
Yeah, you continue with this. If there is a problem, then maybe Dr. Dhulika can present it. Anna?
Okay, sir.
Let's move ahead. We did this slide.
Okay, sir.
Dr. Shireen, are you there?
Yes, ma'am, I'm there. Ma'am, are the slides visible?
No.
Okay, ma'am. Just a second, ma'am.
मैंने आपको एक और भेजा है, वो अपलोड कर दूं। अब वो
They were visible, but now they have disappeared, Shirin.
Yes, sir.
we are uploading it from our end. We will we will change
Ma'am, is
the
it
slides.
visible now? Is it visible now?
Yeah, it is visible. Make it full screen and
Yes, sir.
quickly move down to the slide we were at.
Yes, sir. Ma'am, I'm starting from the CT abdomen.
Yeah. Now it's all right. Move quickly. Huh?
The CTT abdomen was done in the private hospital day 18 of this, which revealed a wedge-shaped splenic infarct involving the tail of pancreas, ischemic infarcts involving left descending colon and left renal artery thrombosis. There was mild free fluid in the pelvis and there was left pleural effusion. With such a presentation, the child presented to us in LNH nearly 20 days after the onset of fever. The past history was not significant. There was nothing significant in the family history. The child was completely immunized for each. In the dietary history, there was a calorie deficit of 33% and a protein deficit of 30%. On examination, the child had a temperature of 103 degree Fahrenheit. Heart rate was 90 beats per minute. The capillary refill time, the peripheries and the peripheral pulses all were normal. The respiratory rate was 23 breaths per minute with no increased work of breathing. The saturation was 99% under room air. Her BP was 98 by 53 millimeters of mercury, which lied between the 50th to 90th centile for age, sex, and height. In her anthropometry, the child was thinly built. Her weight for age was -2 to -3 standard deviation. That is, she was underweight. Her height for age was normal. Her BMI was -2 to -3 standard deviation. That is, she was thinly built. In her general physical examination, she appeared thinly built. There was pallor. In her head-to-toe examination, it was grossly normal, except for the wound over the left foot with discharging pus. The rest of the general physical examination was normal. On examination of the foot, there was a solitary pus discharging wound, approximately 2.5 cross 2 centimeter in size, with a sharp edge and surrounding edema and erythema. On palpation, the wound was tender to touch with an indurated edge and the base was fixed to the underlying bone. So this was the wound as we can see on the left foot of the patient. On a systemic examination, on per abdomen examination, the abdomen was scaphoid in shape, non-distended. Umbilicus was central in position, everted. There were no superficial dilated veins or scars or sinuses, and all quadrants were moving equally with respiration. On palpation, there was limited evaluation due to generalized tenderness. However, there was no organomegaly felt. On the percussion could not be done due to the generalized tenderness, and on auscultation, the bowel sounds were heard and they were sluggish in nature. Other systemic examination involving the CNS, respiratory system, and CVS was normal. So, to summarize the case, we had an 8-year-old female with history of continuous fever of 20 days, pain abdomen and accidental gland injury to the sole of the left foot with pallor, pus discharging wound over the left foot, and generalized abdominal tenderness, who was being treated in a private hospital with significant CCT findings of multiple organ infarcts and presented to PEDS emergency on day of illness 20. Diagnosis in So since the patient had a fever of 20 days with multiple organ infarcts, we kept the diagnosis as dengue with complications, enteric fever, septemboli from left, coagulopathy could be inherited as well as acquired, vasculitis, primary and secondary, and rickettsiosis. We did an investigation in which the CBC revealed anemia. Her hemoglobin was 8.7. There was leukocytosis with TLC of 22,400, and she had thrombocytopenia with platelet count of 80,000. Her KFTs were normal. The LFT showed mild raise in the SGOT and SGPT, and serum albumin was towards the lower level. Was more than 320. PTINR was 1.3, which was almost normal, and her IgM for dengue serology was positive. Rest of the investigations were normal, including the urine investigations, Vidal, HBS antigen, and anti-HCV. So for dengue, we ruled out dengue since the fever was for more than 10 days. She almost came to us with a fever of 20 days. And also IgM dengue serology can be positive for up to 200 days beyond the infection. So we ruled out dengue. And her fever spikes were still persistent. Meanwhile, she had an ulcer on the left foot, which was continuously discharging. Empirical antibiotics were started, that is ceftriaxone and metronidazole. Her pus culture revealed Klebsiella species, and antibiotics were changed according to sensitivity pattern to peptaz and linezolid. Her TB workup was sent in view of fever of more than 2 weeks. However, her chest X-ray was normal, the GACB-NAT was negative, and MONTO was non-reactive. Daily wound dressing was done, taking all aseptic precautions. And at day 22 of illness, that is on day 2 of admission, we started her on low molecular weight heparin and warfarin after consultation with CTVH GB pump in view of the multiple thrombotic infarcts that the patient was having. And serial monitoring of PTINR was done. The second DD that we were thinking was that the discussed wound that she had on the left foot that could have led to a septic embolus. However, for that cause, there should have been thrombi in the veins of the left vein. However, there was no DVT in the veins of the left lower limb. In the echo, there was no thrombus. So this differential was also ruled out thereafter. We did a USG of the kidney, which revealed ill-defined left kidney with no color flow even on Doppler, and the right kidney and its vasculature was normal. The CCT abdomen and chest angio that we did in our hospital revealed arterial as well as venous infarcts in the left kidney. There were arterial infarcts in the spleen and there were infarcts in the bowel, which resulted in bowel ischemia. So we have a patient who had multiple arterial infarcts as well as a renal vein thrombosis. There was mild ascites, liver was mildly enlarged, all bony structures were normal, and there was a fibroatelectatic band in posterior segment of left lower lobe of lung. There was no evidence of any pericardial effusion. So this was the CT. As we can see, I've highlighted the left renal artery ostia. We cannot see the contrast enhancement beyond the ostia of left renal artery. And there was no contrast enhancement in the left kidney. So this reveals there was left renal artery infarct. This is the CT angio film, and if we see the number 4 that has been highlighted, this is the renal artery. We cannot see any contrast enhancement beyond the left renal artery ostia. We were thinking that the patient might be having a hypercoagulable disorder. So we did a coagulation profile in which the only significant finding was a raised D-dimer, which is found in when there are high fibrin degradation products, when there is venous thromboembolism, infections, and malignancy. The inherited workup of thrombophilia came out to be negative. We sent a homocysteine protein CST-MTHFR mutation. All of them were negative. For the acquired causes, we ruled out antiphospholipid antibody trauma. Everything was normal, negative. So our patient had arterial as well as venous thrombosis. As we all know, arterial thrombosis occur in cases of endothelial injury, that is when there is vasculitis, rupture of atherosclerotic plaque or trauma. And venous thrombosis occur in stasis and hypercoagulable states. And similarly, their treatment also depend on that. So in arterial infarcts, there is more platelet composition to the thrombosis as compared to fibrin. In venous, there is more fibrin as compared to the platelets. So the treatment is also antiplatelets for arterial thrombosis. Venous thrombosis ke liye we give anticoagulants. Our patient had both arterial as well as venous thrombosis. And the trend of the investigations was that the patient was constantly having anemia. TLC remained more or less same. DLC remained predominantly neutrophilic, and there was a shift in platelets. Initially, we had thrombocytopenia, and now we were proceeding towards thrombocytosis. Her platelet was 7.3 lakhs. We ruled out hemolytic anemias. We also ruled out acute promyelocytic leukemia because that presents as a prothrombotic state. We did a bone marrow aspirate and biopsy, which revealed no features of leukemia. The only finding was mild lymphohistiocytosis, which reveals a chronic inflammatory state. On day 23 of illness, patient developed 2 subcutaneous nodular lesions over the left flank, which were tender, each approximately 1 × 1 centimeter, and there were no overlying skin changes. Fever was persisting. The patient was having fever of 104 degree Fahrenheit. She was now bedridden. There was generalized body ache, especially over the hip joints. Her mobility was restricted. There were no other joint movement, and the spine examination was normal. Thrombocytosis with platelet counts increased from initial 1 lakh at presentation to 7.3 lakh now, as already discussed. And echo was done to rule out any embolus, so there was no thrombus or vegetations in the echo. So with this presentation, we considered the possibility of a vasculitis, and all the features were suggesting a vasculitis in this patient. The patient predominantly involving the vessels of the patient that were predominantly involved with the medium vessels, that is the renal artery, the renal vein, which makes the possibility of childhood polyarthritis nodosa, cutaneous polyarthritis, and Kawasaki disease. So the patient was not fitting in these diagnoses as well. However, she had some vasculitis, not fitting into polyarthritis nodosa, Kawasaki, or any secondary vasculitis. We ruled out malignancy as already discussed. She was not fitting into the criteria of SLE as well. Her autoimmune profile was also negative. And a skin biopsy was sent from the flank nodule, which revealed hyperkeratosis with focal acanthosis, which was a non-specific finding. That flank lesion progressed over 14 to 15 days, and now it was of the size of 4 cross 5 and 3 cross 3 centimeters. They had become tender, they were indurated, and there was pus underlying those areas. So this was the picture of the flank lesion, as we can see. It appears indurated red with pus underlying that area. We did a PID profile, which was negative, that is primary immune deficiency profile. Her HbA1c was normal, and pus culture from this site came out to be sterile. We considered a possibility of foreign-induced skin necrosis. So we gave FFP for 10 days. And a repeat pus culture was sent from foot ulcer, which revealed pseudomonas. Pus CB-NAT was sent from that site, which again came out to be negative. And antibiotics were upgraded accordingly. On day 50 of illness, the patient complained of left thigh pain. On examination, her left thigh was tender. There was no local rise of temperature. There was no swelling over the thigh. She also had developed a knuckle deformity in the thoracolumbar spine and pseudoflexion deformity of the left hip joint. The USG of her left thigh revealed an abscess development, and it was a psoas abscess, approximately 5.2 cc's, extending into the left hip joint. Orthopedic opinion confirmed our findings, and possibility of port spine were kept. It revealed a collapse of L2 and L1 vertebra, and MRI dorsolumbar spine was done, which revealed complete destruction of L2, L3 intervertebral disc. So this is the picture of the collapsed intervertebral space, collapsed vertebra, and normal. Tubercular spondylosis was absent. Vascular renal infarct with anemia, with left foot abscess with severe things. Now we reviewed the literature in which similar findings were there as our patient. So we reviewed the pathogenesis of tuberculosis-associated vasculitis and venous thromboembolism. We found out that tuberculosis-associated prothrombotic states and vasculitis occur in the following pattern. It could be associated with primary vasculitis, in which there could be Takayasu arthritis and IgA vasculitis. It could lead to cerebral arteriopathy, leukocytoclastic vasculitis, and deep vein thromboembolism. When TB leads to primary vasculitis, it is seen that there is a causal link between Takayasu arthritis and tuberculosis due to granulomatous nature of both the diseases. And it is also supported by the increasing frequency of Takayasu arthritis in patients from continents with high prevalence of TB. Infection with TB aid in arthritis because of cross-reactivity between vascular endothelial peptides with mycobacterial antigens. Cross-reactivity is in the pattern that there is a heat shock protein antigen of Mycobacterium TB, which cross-reacts with human heat shock protein, which is present in the endothelium and smooth muscle of blood vessels. So patients with Takayasu arthritis have an increase to human heat shock protein 60 and mycobacterial heat shock protein 65. Additionally, there was an increase in circulating IgG isotype antibodies against these types of antigens. Second, we found out TB is associated with IgA nephropathy. Active TB disease results in an increased IgA levels because of generation of specific IgA against mycobacterial antigen 60. So this IgA forms immune complexes with mycobacterial antigen, And deposition of these immune complexes in mesangium of kidney, activation of alternative complement pathway and the lectin pathway, which causes IgA nephropathy in TB. TB can also result in cerebral arteriopathy. This vasculitis involves the perforating vessels of the brain. It is a characteristic hallmark of TB meningitis-associated stroke. The mechanism is that it leads to necrotizing panarteritis as a result of a chronic exudative basal meningitis. There is segmental constriction and spasm of vessels located at the base of the brain, which provokes thrombosis and vasculitis. There occurs hydrocephalus and dilated ventricles, which stretch the compromised brain vessels and possibly they aggravate ischemia. TB is also an associated leukocytic. As we all know that venous thromboembolism involves the virtuous triad, which involves three things: stasis of blood flow, hypercoagulability, and endothelial injury. So with thromboembolism is because there is enlargement of lymph nodes, which can lead to pressure of venous. The venous is as seen in appendix, which is the peripheral muscle contractions for venous circulation. There occurs hypercoagulability, the innovation in the blood flow, which increases the plasma level of factor VIII fibrils and plasminogen activator inhibitor 1, which result in decreased plasma level of protein C and anticombin C, which are the anticoagulants, natural anticoagulants in our body. Endothelial injury occurs as there is chronic inflammation which is linked to the presence of Mycobacterium tuberculosis. Cutaneous manifestations among all cutaneous TB, childhood cutaneous TB proportion is 18 to 53%. And compared to adults, children with cutaneous TB have a higher propensity for lymph node and systemic organ involvement. The prevalence of systemic involvement occurs in 12.7%, 53% in Indian studies. On reviews, no case that has been reported which matches the exact clinical profile of our patients. So that is what made it unique. Now the patient's response to ATT and current status child. Abdomen subsided within the first weeks of therapy. Forgot was bed, spinal days, and cognition reading. Patient did bed rest for 2 to 3 months, and then she started walking. Now she walks without support and goes to school as well. To resolve 1 month of ATT. Her internal organ marks, P2SD renal Doppler was done. Right kidney normal study, whereas the left renal artery not be delineated due to changes. It was intact, but with normal cavity and no urinary complaints. The non-healing ulcers, all the 3 lesions got healed with scar over a period of 1 month. So this was the initial foot ulcer that we've seen. And after 1 month, it had lesions on the flank. These lesions which had the underlying pus we had seen initially, they also resolved with bleeding. Current status of child, ATT was started and the child has completed 12 months of ATT. Appetite return, she had weight gain. Initially, she had a weight of 14 kg at discharge. She's 23 kgs. Currently, the child is afebrile, symptom-free, walks without support, plays with friends. I'd like to discuss slightly more regarding why you think why the chest is yes. So there are ultimately diagnosed as having multiple organs, but why had a normal X-ray and negative GACB-NAT in a proven of 4 times. So as we know the pathogens of extrapulmonary TB, TB from the environment, healing, hematogenous dissemination, so whenever early hematogenous dissemination occurs, in non-primary focus, or we could call secondary TB without primary focus at lung. And latent TB upon deactivation can ultimately lead to extrapulmonary features, that is the node cutaneous renal TB, vasculitis, and skeletal TB, which was seen in our children. There can be cases of disseminated or extrapulmonary TB without primary focus in lung because of early hematogenous dissemination. There was a normal chest X-ray because the early hematogenous dissemination, there was a negative GACB NAT, there were no respiratory signs in our patient. So why was MON2 non-reactive? So as you know, there are individual variations in administration and interpretation of MON2 result. There is a low sensitivity and specificity. It can be false positive or false negative. So among the causes of false negative, disseminated TB disease is one of the causes. Why was no microbiological confirmation in our case? So for bacterial TB demonstration and extrapulmonary TB cases, it is difficult because the sensitivity of NAT for MTB detection in pus, respirator biopsy specimen from nodes, tissue samples is low to moderately high, but it is poor in pericardial, aesthetic, and synovial fluid sample and still poorer in fluid. We had sent pus from skin lesion, USG guided aspiration, and pus AFB as well, and both were negative. There can cases of extrapulmonary TB without non-reactive MON2, negative CB NAT, FB staining of extrapulmonary specimen. Then diagnosis of TB in such a case is made on clinical and radiological basis, and we have to rule out other possible causes for the symptoms. That is it. Thank you, everyone.
Thank you, Dr. Shireen. This was indeed a very well worked up case, a case which presented with some uncommon manifestations of TB. So the case brings forth a very important lesson that even if the manifestation may be different from what we normally see in usual circumstances, but we can still reach a common diagnosis. So even when we are dealing with cases with unusual presentations, we should never forget common illnesses that we have to deal with in our clinical practice. So I thank the team from MAMC, Dr. Anurag and Dr. Shireen, and the entire team for this very well worked up case. If there are any questions from the audience, they can now put up their questions. Any questions?
I have been answering a lot of questions on the chat.
Yes,
And if there are any more, we would like to answer.
Feel that there is any question which...
Yeah, I just want, I'm Dr. Shikha Malik. Can I ask a question?
Yes, please.
There is a similar patient at our place, just admitted 2 days back, had come with fever, history of fever and swelling of the left lower limb, and is now diagnosed as a case of tuberculosis. So again, this was vasculitis of the smaller vessels. Do we also see such swelling of single limbs? I mean, a lower limb completely swollen, and on Doppler, of course, there was a big clot. So is there also vasculitis or inflammation of the larger vessels as well, wherein the clot is formed?
Ma'am, a bit difficult to answer because this is a very uncommon presentation. And in fact, if you ask me, when we presented this case in the department, nobody initially said it was TB. Everybody placed autoimmune to inflammatory to vasculitis. So it is a bit difficult to directly say that any case presenting with thrombosis will be or most probably be or could be TB. It is one of the rarer causes because we see vasculitis usually in TBMs. When we look at TBMs, the pathophysiology of TBM is vasculitis. Here you'll have to work up, look for causes, and if anything comes positive, yes, think of TB definitely. So TB can present with anything, anywhere, and you can get all sorts of manifestations with tuberculosis.
So this reminds me, there was another case with us which also had dermatological manifestation and was presented similar to what your case is presenting, almost similar case. So, and the thing was, he had gone with a complaint of corns and calluses. Ultimately turned out that these calluses and corns were because of tuberculosis, and ultimately turned out to be tubercular and similar presentation neurological. So I think TB is now presenting with vast variety of the clinical presentations, and one must look also for a country where the number is increasing again. What we are seeing in AIMS Bhopal, that now we are getting difficult to treat tuberculosis and all varied presentations coming up in larger volumes. Maybe it is a good programs that are going on, but yes, they're coming. And for a child now, we will also discuss this case later, if next time when you have the Zoom meeting. And we should know why these things are presenting in a very different way. Maybe that it is the immunity is much better and it is taking a very prolonged time to actually present, and therefore these manifestations of vasculitis, because vertebra and vasculitis is one which takes a very long time for inflammation. So that could be one reason. And of course they are coming in high numbers, so again we probably have to again go back to basics and start right from where every case was diagnosed as tuberculosis. So first, and to rule out tuberculosis, and then next. So malaria and tuberculosis were always taken as the first DDs. So anyways, thank you so much for such a wonderful presentation and sharing the knowledge.
Ma'am, we thought of TB in between also, but everything was coming out to be negative. In fact, the foot ulcer, the most confusing part was that the patient said it is because of the glass shard injury in the previous hospital, as the child stepped on a piece of the vial, broken vial, and she developed a lesion there. And she was very vehement. The attendants were sure. They said they removed a piece of glass from the wound. So that confused us. Even then, after that, we sent a biopsy to find out what is it, but it did not point any finger towards tuberculosis. So ultimately, when there was a pain in the thigh and the collection was seen, and then we did a MRI. That is the second one. The first one, Shirin has not shown it because of the lack of time. The first MRI was normal, which we had done initially. It was the second MRI when we saw the collapsed vertebra and we were surprised. So yes, TB can present in all forms, shapes, and sizes. And this is one of the ways which caught us. We, in fact, had a primary liver abscess which turned out to be tubercular. Normally, liver abscess is a secondary feature of disseminated COX. But in the another case we had recently, Dr. Shirin was again a part of it. It turned out to be a liver abscess. Our PG sent a CVNAT on the liver abscess, but that came out to be positive. We started ADT and the child improved. So anything can happen.
This is a very important lesson. This is a very important lesson which Dr. Ragi have said, that always send, whenever you're sending investigations, do send investigations for tuberculosis. And I always feel the sending of EPTB specimens is very important, you know. Always make 2 dry slides for ZN staining, then 2 slides in formalin, you know, for the histopath or the cytology. Uh, because, you know, sometimes during treatment you are stuck whether your child is improving or not. So the histopath or the cytology will give you the answer whether the, you know, the caseation necrosis is, healed or not. Still caseation is there. So, and the last thing is the major chunk needs to be sent in the saline for NAT and culture. So sending extrapulmonary TB specimens is very important. And as we have seen in this case, you know, differential diagnosis of tuberculosis should always be kept in mind. In fact, I had a child who presented with a purpuric rash, you know, something which we are very familiar with meningococcemia. You know, typical purplish when that child.
Sangeeta, can I say something?
Ji, sir. This is Dr. Ashok Bhardwaj. He is a National Task Force Chairman. Yes, sir, please do.
Madam, whatever you discussed, we did it in Himachal Pradesh. So whenever an operation take place in the operation theater, so we have trained our OTAs to please one sample go in formalin to the biopsy, another sample in normal saline should go for CBNet testing. So for that purpose, we have provided tissue homogenizer to all medical colleges in the state where VSL level 2 facility is available. So if we do this throughout the country, if VSL2 facility is available and this tissue homogenizer is provided, then we will be able to diagnose better than anything else. So my take is that we must promote second sample in normal saline for CVNet testing. That is why I come in between. Thank you.
So that is very important, proper SOPs of sample collection. We are doing so much, but missing out on the sample collection. And this other thing is always to send to an accredited lab, because that is another very, very important thing, which we tend to ignore. So coming to this case which I was discussing, this case presented with something like high-grade fever and a meningococcal rash, and there was typical history of, respiratory tract viral kind of respiratory symptoms. So to our utter surprise, that also turned out to be tuberculosis. Because I took the specimen, the prick from that rash, as is advocated to send for meningococcal. मैंने कहा चलो हमारे क्या है इसको टीबी के लिए भी भेज दो, and it came out to be tuberculosis. So I would say that we need to not forget our basics. Go back to the history, go back to the proper clinical examination. What we always say that go to the easily accessible sites like cervical lymph node, and in this case, like this ulcer, which was not taken to be tuberculosis, but that clinched the final diagnosis. So there is one hand raised for long. I'm sorry. Yes, sir, Dr. Jackishan, sir, please. Dr. Jackishan?
Sir, unmute please.
Unmute yourself. Yes, sir.
Am I audible?
Yes,
Yes,
yeah.
yes, sir.
So it's a well-known fact that during the primary tuberculosis, the hematogenous spread occurs, and the hematogenous spread, once it is occurring, the foci can settle down in the blood vessels as well. The vigor focus is known to be there. The rich focus is known to be there, and they are usually settling in the arteries, but can settle in the veins as well. So once there is the immunosuppression later on, these foci can lead on to the arteriitis and can cause somehow pulvitis type of the lesions. And here in this case, both the arteries are involved and veins are involved. It's very difficult sometimes to get a positive specimen from these sites, extrapulmonary sites. But indirectly we can have the ADA in the serum, and in patients with the disseminated tuberculosis and even in primary tuberculosis, the serum ADA was on the higher side as compared to the normal or the pneumonia patients in our study. In this patient, the source abscess, we could get the specimen there and culture can be sent. And the blood culture may not be positive. The CVNet may not be positive in the blood, but blood culture can yield the positivity in the mycobacterium tuberculosis. And in this case, there was renal artery involvement. So the urine specimen culture could also yield some positivity rates, although the culture positivity are very less, 10 to 20% or 30%, but that can be the addition. So that say that in this type of scenario where there is involvement and embolism or thrombosis, we should be thinking of the vigor focus and in the arteries and the veins. And the dissemination, skin where involvement is known to occur. Normally there is the monotropism can be there, but there may be even the lichenoid species and the others, the scrophulodema type of the lesions can also be there in the skin as well. So here that can also explain. So we can think on those lines as well in this type of the scenario. Thank you.
Dr. Sangeeta? Dr. Sangeeta? Hello?
Madam, yes, sir, please
Hi.
continue.
Anurag, I need your comment regarding the blood culture, because there are few studies which said that if you do in the initial phase of bacteremia, but it is not going to be contributory for mycobacterial tuberculosis. I have a strong difference of opinion with my own colleague from my institute. We don't see,
I
because
don't.
that's, and it's not a one of the recommended modality to obtain blood culture in these patients.
So
Because
bacteremia is known to occur in HIV setting of the disseminated TB, but once there is a hematogenous involvement, then the culture positivity rate can be there, although this is not very high, but and their literature says that it can be there in 20-30% of the cases also of the disseminated TB as well.
Sir, for disseminated TB, I have yet to see culture positive, but as you are saying, your wisdom is more than mine. But then now we have the CBNet, which is coming up, which is a different kind of a cartridge than the presently available, which the blood can also be, put in as a specimen. Because the present cartridge which is being used for NAT or true NAT, they have blood as an inhibitor. So we do not take the sample which contains blood. But then there is a different cartridge which is, WHO has recommended, that CBNAT on blood in cases of disseminated TB or miliary TB, but that cartridge is different. Now coming to the ADA, I would say that it's positive for all cases who have a sort of infection where the WBC count is raised, neutrophilia. So ADA for children, that is one of the reasons, is not included in our guidelines.
Yeah,
So
that is
it's a
there.
very important entity for adults, because your next differential diagnosis is always malignancy. But for us, the next differential diagnosis is usually an infection only. And in majority of the infections, ADA will be raised. So that is the reason we do not, only if we are thinking of a differential diagnosis of malignancy, like if it is a malignant pleural effusion in a child or a mesothelioma, only in such cases we send ADA.
Okay.
Any other questions? Any comments?
Sir,
Yeah.
can I ask?
Yeah.
Anurag sir, this is a very good case presentation. Actually, lot of learning is here. I just have one thing want to know regarding the TB vasculitis. Is there any role of aspirin actually in, or any other anti-platelet just like drugs, sir?
Uh, Actually, what you said is not wrong. We started warfarin in this child, and I think we discharged him on some antiplatelet drug. I don't remember exactly which. Shirin maybe will remember. In fact, although it is not a part of guidelines, we sometimes use aspirin in our TBMs also, and there is role of infliximab also in some studies, of course, not part of standard guidelines. So it is not recommended over the well, across the spectrum as such. But yes, I think these drugs should have a role, especially when you have vasculitis.
And is there any CT after starting the anti-TB drug? Is there any CT was done to find out
Yes,
if the
yes.
effect was improved or not?
Yes, yes, everything was done. We actually had the limitation of time, so we did not show you everything. It's a 90 plus slide presentation. Shirin, do you have that CT scan? So we lost the kidney on one side,
Okay.
and but the gut was saved, and everything else recovered other than the kidney which we lost. So the other kidney is remaining, one kidney we lost, and everything reverted back to normal other than that. Shirin, can you throw more light on it if you have the CT or something with you? But the child is perfectly all right, comes to us and has completed her ATT just recently and is coming to us, came to us around a few months ago and was doing very well. There were no fresh episodes of thrombosis. We again worked up for thrombophiliac states and we could not find anything. Everything was negative. We even did a genetic workup for thrombophilic states. Again, we did not show it in the presentation. It was going on and on and on, and it was negative.
Yes, sir. You have done a lot of work in this case actually. Now all things were ruled out and later on the TV was found out. Now.
Yeah. So a lot of investigations, consultations with the CTVS people, with the hematology team, everybody we were keeping in touch with, dermatology people we called up for the skin lesion, but nobody even dreamt of TB in the मतलब जैसे कहते हैं कि the last of their diagnosis is the last thought process कि शायद TB हो. Nobody thought of it at all.
Mhm. The other thing is, 1 year of ATT has to be given in such cases because
Yes.
it is osteoarticular involvement and also it is disseminated TB.
Yeah.
So,
So we gave 1 year. Yes.
so for the house, I'm just telling, for cases of CNS TB, TBM, miliary TB, disseminated TB, osteoarticular TB, the minimum under the program is 1 year. So, as was in this case had disseminated also and bone also, pot spine. So, very nicely you did,
Yes.
1 year ATT.
Yes, ma'am.
Any more questions?
Any comment? Any questions? Dr. Anubhav, would you like to share any interesting question which was asked? If you
In the
feel
chat
that it
box.
needs to be, read out with your answer for the
Yeah,
information of the house.
so I think everybody was thinking on the lines we were thinking of regarding why is it not a autoimmune phenomena? Why is it not a vasculitis? Why did you think of dengue? So we have explained it in the case as we went down the presentation.
Yeah.
So I think everything is answered.
Mhm.
And CGD, what did you work up for immunodeficiency? Yes, we worked up. We got our flows done, flow cytometry is done. We got antibody titers. We even looked for CGD, although the history was not suggestive because it was just the single episode which the child had. But still, we got our NBTs done. Everything was negative. So we worked up extensively thinking of all possible scenarios. So all these questions were coming as the presentation was going on, and so I was answering along the way. Yes, we tried to do an aspiration from the pot spine area, but we did not get anything. And the orthopedician clearly told us कि डॉक्टर साहब कुछ नहीं आएगा आप कितना ही नीडल डलवा लो ये मेरा पक्का गारंटी है and nothing came from the pus we tried to aspirate which was visible on in pot spine on MRI. And so we could not get a microbiological diagnosis. That is right. It is really difficult in these cases, but of course the response is there and the child is all right, so it was TB.
That is not just from not sending specimens. So we should always send the specimen because you never know. In your case, it did not grow, but we have had cases where it grows from a, you know, forgotten small sinus. So always please send specimens. We should not be miser in sending specimens.
Definitely, yes. So we sent our pus for CB nats. We sent our tissue biopsy from the abdominal region, from the lower foot lesion for CB nats, and looking for granulomas, caseating granulomas or anything, but nothing was visible, and nothing came positive.
Okay, so I think we can now move on towards the conclusion. But before we conclude the session, I would like to invite Dr. A.K. Bhardwaj, Chairman of the National Task Force, for his concluding comments. Dr. Ashok Bhardwaj.
So why signal had gone. So thank you very much. It was a wonderful case. So I thank everybody, mostly Dr. Sunit Sangeeta, for giving me a chance. It was always learning for me in many cases. So I was again I will request at each time the state should concentrate on the capacity building of pediatrician. It is lacking wherever I have gone, which medical college I have visited. They say that we did not have any sensitization session. Why the college or by the state TV cells. So I will request all state TV cells who are present here in the STOs so that please consider the case of sensitization of pediatrician in your state so that they follow the program. So thank you very much. Thank you.
So, sir, before ending, I would like to add what Dr. Bhardwaj has said that our TB team needs to get sensitized for starting for doing family surveys and starting and what do you call it? आपका जो 6 months INH prophylaxis देते हैं TPT, TB preventive therapy. I have a child of TBM who is literally brain dead. The other SIB also died because of TB, and there is another SIB who has TB, and nobody started TPT to these children. Otherwise, this child would have not been brain dead on ventilator at this point of time. So TPT is so important. Please focus on it. Do family surveys, look for contacts, and treat or give TPT, whatever is required. Very important.
So
TPT is very important. Without this, we cannot think of ending TB from the country.
Definitely, sir. So this message has to go down to the last person who is managing TB in any form, anywhere in the country.
Thank you, sir. Thank you.
Say that, under whenever we do the Nikshay ID, there are columns where you have to enter the contact details, the detailed family contacts, and then it enters into the system. So I think the input has to be from our part also, the person who's starting the registration on the Nikshay portal. So that is another very important area. And I would also like to say over here that the efforts of Sathi, this is an organization, and Dr. Satish always joins us. And this is an organization which is doing in 7 states, spreading the pediatric TB knowledge. So I'm very thankful to them for their hard work, and continue that, and we will support you, as I have showed you that NITRD pediatric department is always there for you. Dr. Satish, if you are there, I would like if you can say one or two, if you're around, because you were there in the start of the session. Doctor है Dr. Satish? नहीं. Chalo. So with this, thank you so much, and I think we will be back again. 17th of February. So 2 to 3 p.m. and with another very interesting case. So I request all of you to pass on this word to your friends. I think it's a learning experience for all of us. So we need to spread this knowledge. You create more spokes so that more people they join in. The link which we share, please feel free to pass it on further, so that our enrollment it increases, and that will be a source of encouragement for all of us. So with this, I think we end today's session. Dr. Dhulika.
So thank you all for joining today's session. It was a very fruitful discussion that we had. As ma'am has already mentioned, our next case would be on 17th of February. That's the third Tuesday next month. And we will come up again with a very interesting case discussion, which will be useful for all TB officers and pediatricians who are treating TB patients. So till then, goodbye, and see you all in the next TB Eco Clinic on 17th of February.
In fact, I would also encourage you, if you would like to, anybody would like to be a part of this activity, present their own interesting cases, because we want to increase our base rather than those same institutes like AIMS and PGIs and NITRDs and national institutes. I want that most of you need to come forward and join hands, and we will be sharing the अपना वो डाल दो email ID, ठीक है, so that whoever is interested, we would love to have you present your case.
The post-test link is also available in the chat box, and the meeting would continue for a while till you all can attempt the post-test questionnaire as well. So thank you all for joining in once again. See you all in the next TB Eco Clinic on 17th of February. Goodbye.
Thank you. Thank you so much.
Yes, sir. Thank you.
Bye.
Thank you, Sharon. Bye.